Good morning. Good afternoon, respected colleagues and judges. So I'll be presenting my topic, adjunct surgical procedures to managing corneal ulcers before keratoplasty. So these are the topics that I'll be discussing. First, tarsorrhaphies, superficial keratectomy, PAC CXL, conjunctival flaps, and keratitis-associated corneal perforations. So first, while I'll be starting with tarsorrhaphy. So what is the advantage of tarsorrhaphy versus patching? Tarsorrhaphy gives more oxygen delivery to the corneal epithelium, easy eye drop administration with retention of partial eyesight, examination of the cornea is possible, and overall faster healing is there. So tarsorrhaphy can be temporary or permanent. Temporary can be a central suture or a drawstring tarsorrhaphy and a pillar tarsorrhaphy. In temporary, it can be lateral or medial. So while medial tarsorrhaphy, we have to make sure that we don't injure the canaliculi. And in drawstring tarsorrhaphy, it is a preferable technique when we want to keep the tarsorrhaphy for long. So basically, we take 3 bolsters, 2 of 2 mm, 1 of 1 mm, and we tie a knot at the 1 mm, which can be like a bowstring. We can loosen or tighten it when we want to examine. So for permanent tarsorrhaphy, we can have a glue tarsorrhaphy, lateral permanent, and a Botox tarsorrhaphy. So glue tarsorrhaphy becomes more important when especially the patient is immobile, the patient is in ICU. It can be done as a bedside procedure where a 1 mm of adhesive along the lash line is put, and you can just close the eye, especially when patients are having exposure keratitis induced ulcers, associated ulcers or perforations. Permanent lateral, the patient sees and can be examined 2 to 8 weeks. Done specially in herpes associated nerve palsies where the eye stays open. Botox tarsorrhaphy where there is an anterior transcutaneous chemodenervation of the LPS muscle. So for the lateral tarsorrhaphy, we can keep for an indefinite time. Cyanoacrylic glue generally for 1 week can be kept for more. Botox toxin permanent acts for 3 to 6 months, and drawstring tarsorrhaphy for about a month. So this is a surgical video of a superficial keratectomy where we use a superficial keratectomy followed by a tarsorrhaphy where we have taken sample from the periphery, and we are trying to remove as much of the cornea as possible, infected cornea as possible. Not too much aggressive because then it could perforate, and then we have done a tarsorrhaphy. You have to make sure that the patient looks in the center. Ask the patient to look straight, because if the patient starts moving towards the side, then the location of the tarsorrhaphy doesn't really overlap with the affected area. And then this is a temporary suture tarsorrhaphy. So then you give a knot. So in superficial keratectomy, we manually dissect the epithelium and sometimes go up to the Bowman's layer, often with a blade, and to create a smoother, more regular surface, we can combine it with the DB polishing, diamond burr polishing. It can be done bedside also, should be avoided, ideally done in OT, and it helps to remove irregular corneal layers and smoothen it, and the tissue that we take, it has both diagnostic and therapeutic roles. So coming to conjunctival flaps, the conjunctival flap, it provides a conjunctival blood supply, helps deliver immunoglobulins and systemic antibiotics and collagenases, which help support and also help in faster healing. Non-living tissues like amniotic membrane do not offer this advantage, although they can be used as a packing agent. So conjunctival flap can be used in therapeutic indications like unresponsive infective keratitis, severe chemical injury, PED, corneal limbal disease. Aesthetic use when we have to do it before a cosmetic shell, or we plan a future PK for the patient. Tectonic for corneal perforations or any glaucoma surgery related complications where there is thinning, corneal or scleral melting. And analgesic purposes, especially in patients with bullous keratopathy with poor visual prognosis, where we don't intend to do a PK later on. So conjunctival flaps can be a bipedical flap where we take 2 pedicles and we put it all across the cornea. In partial limbal advancement flap, we are taking the flap from the superior part and just pulling it over the area where there is the perforation. In a pedunculated flap, we are raising a peduncle shaped, and it stays attached in one point, and it is used to just cover the affected area, especially useful in small rheumatoid associated perforations where planning a PK planning a patch graft might not be useful because of the risk of associated melts in the later stages. And this is and then we can do a Gondiser flap where we create a large flap where a 3 mm incision is given on the retrotarsal fold. We separate the tenons and the conjunctiva and then raise the flap and put it over the cornea. It is especially useful when there is a failed PK with poor visual prognosis. We can do a Gunderson flap for symptomatic patients who are having repeated bullae. So this is a patient of a partial pedunculated flap where we have taken this pedunculated flap and we have reposited it over the over the affected area. These are the representative images from a surgical paper. Conjunctival, this is for post-RA melt. The problem with conjunctival flaps is it induces corneal vascularization, which is both useful and can be a cosmetic issue for some patients. So coming to corneal perforation, first we come to medical management. First you have to treat the underlying cause, whether it is due to any rheumatoid or a sterile melt, we have to treat accordingly. Give protease inhibitors, tetracycline, vitamin C antibiotics, topical or systemic. Steroids should be very cautiously used, can be used especially when there is significant inflammation in some of those viral hepatic lesions. Aqueous suppressants need to be given to manage these. So now coming to the corneal perforation management based on size, less than 0.5 mm or self-sealing, you can just give a BCL with aqueous suppressants and antibiotics with vitamin C and doxy cover, and you frequently follow up the patient to see if there is any progression or not with ASOCTs. 0.5 to 2 mm, you can give a fibrin glue, cyanoacrylate glue, AMT or a tenon patch graft. 2 to 3 mm, we give a cyanoacrylate glue or a patch graft, and more than 3, we have to do a patch graft or a multi-layered AMT can be tried. Glue BCL, always use a non-compressive lid speculum. 1 to 2 mm of epithelium around the perforation should be debrided and the wound should be dried, and remove any incarcerated tissues. Useful if you make a side port, inject air and then you separate. If air is not possible, then you use a viscoelastic to separate or create a plane, and then you put the BCL over it, glue over it. This polymerization can occur in minutes, and you always have to recheck for leaking, otherwise you have to repeat place the BCL. The BCL should be placed only after polymerization, otherwise it forms a complex, and whenever the BCL moves, the glue moves along with it. And always check the patient after 30 minutes on a slit lamp. So in the interest of time, I'll be skipping this. So methods, you can do a needle with a 30 gauge, make a small drop and you put it over the affected area. After the precautions, a sponge stick can be used, the back of a disposable PVA sponge or a sterile disposable drape can be cut in the size of the intended perforation, and you can place it over it after the glue. Put the glue over the drape and then you place it over the perforation. Precautions of drying, etc. should be used. So tenon patch graft, you generally take the superior part and not the exact superior, either supranasal or supratemporal. Always oversize this graft. Same, clean the 2 mm around the perforation and you tease out the graft with the blunt cannula so that it spreads out, because the tenon graft has a tendency to fold on itself. And then once it's spread out, take a glue, put the fibrin glue and then you put it with the patch graft in place, and then you can suture it alongside so that it stays in place. PAC-CSL, which is photoactivated chromophore corneal cross linking for both bacterial, fungal, mixed infections. Reactive oxygen species are created, and UV radiation of 7.2 joules per centimeter square, 8 centimeters centered over the ulcer can be used. So I have used it, but I am not very convinced with it, so I don't generally use it in clinical practice. It is useful for small ulcers, and 1 mm debridement can be done for better penetration. AMT, multi-layered or threatened perforation up to 5 mm promotes reepithelialization and yes, ma'am. And it induces less vascularization than conjunctival flaps may be used. Thank you so much.